Welcome to Staying Connected, a podcast where I talk to people about their stories with VEDS, Marfan, Loeys-Dietz, and related vascular and aortic connective tissue conditions. This is your host, Katie, and before we get into the show, I want to remind you that the views, information, and opinions in this podcast are those of the individuals involved, and the information presented does not constitute medical or other professional advice or services. Any opinions that I express in this podcast are my own and not of my employer. Welcome back. In this episode, we're going to talk to Dr. Shaine Morris, a pediatric cardiologist at Texas Children's Hospital at Baylor College of Medicine in Houston, Texas, who's well known in our community. Shaine was on this show in 2022, and in this episode, she joins us again to share updates in research and care for people with VEDS, Marfan syndrome, and Loeys-Dietz. Before we jump into the interview, if you like this podcast and want to support our community and our efforts to raise awareness through this show, you can buy merch in my Printify pop-up store, make a one-time donation, or support the show by joining my Patreon. This show wouldn't be possible without the continued support of my Patreon subscribers and donors, so if you've already been supporting the show, thank you. Check out the episode show notes for links to ways to support the show. Let's get into the interview with Shaine. Hey Shaine, thank you so much for coming back on the podcast. I was listening to our interview from 2022 this morning, and I'm just still so grateful for you, and I loved that interview and all your research too. Would you like to introduce yourself to people who don't know you or maybe didn't hear that episode?
Yeah, sure. Thanks, Katie. Thanks for having me back. As you know, I'm a huge fan of your podcast, and I'm really eager to be back here to talk today. But anyways, I'm Dr. Shaine Morris. I'm a pediatric cardiologist at Texas Children's Hospital in Houston, and I'm a cardiologist that specializes in genetic conditions, and especially when those that affect the blood vessels. And one of my main interests is vascular EDS, and I'm fortunate enough to take care of a lot of children with vascular EDS and to work with a lot of the affected parents. And I see myself as an advocate in the community, and I think we have the largest pediatric VEDS clinic in the U.S.
That's pretty amazing that you have so many patients with VEDS. I mean, I feel like, so one of the things that I feel like is that when I look at the stats for who listens to this podcast, there's like a huge dark area around Houston. And I think it's because you share this podcast with your medical students and other researchers and stuff, which is so awesome.
Oh, okay.
And it does feel like there's this really huge diagnosis bubble going on, especially in that area, I think more so than others, which I know that there's other researchers out there in that area, but I definitely contribute that mentally to you and your advocacy. So thank you for that.
Sure.
When we talked in 2022, I think the Clarity study that you were doing was pretty new. So Do you want to talk about how that's going?
Sure. Yeah, I'd love to. So Clarity is an acronym for our registry. It's the Collaborative for Longitudinal Aortic Research in the Young. And it's a registry for rare genetic aortic and aortopathy disorders that focuses on young people. We have had a few other registries, one led by the NIH called GenTAC from a few years ago. And there's a Montalcino Aortic Consortium, which is run by an incredible collaborator of ours, Dr. Milowicz. But what I noticed is that there was a deficiency of young people in those because most of the collaborators were adult geneticists and surgeons and cardiologists. And there wasn't a lot of longitudinal data because a lot of people go to these super specialized geneticists to get a diagnosis, but aren't necessarily followed long-term over time. But in our clinic, genetic cardiologists sort of serve as sort of a vascular surgeon for kids and follow patients over time. And so almost every pediatric cardiologist that follows VEDS and other rare disorders follows them serially. And so we recruited centers that follow a lot of children and young adults. And when we were just over 3 years, so you're right, it was just starting then. So we've just passed our 3-year mark this year. And our goal was to enroll 3,000 patients. This isn't just VEDS, it's also Marfan and Loeys-Dietz and other conditions. 3,000 patients in 3 years. We're not quite there, but I think we're at 2,200.
Wow.
Which is the largest collection of pediatric aortopathy patients ever collected, I think. even if you focus on pediatric patients, larger than the European study. So it's been going really well. We have 25 centers now contributing from the US and North America. And we have many other centers. I think there's 5 centers that are trying to get up and rolling. And so it's really, we're really, really excited. And what this allows, no center has enough patients to get really great data. So by joining Clarity, a center can say, hey, I want to look at this question, like someone's looking at heart transplants and connective tissue disorder. Someone else is looking at attention deficit and treatment in VEDS, right? And so if they're part of our group, we can just give them all the data. So even a small center that might have 10 patients, they'll get all of Texas Children's data, de-identified, of course, and be able to write up projects. And it makes our research just so much more powerful. And there's sort of 2 ways. A center, like a person like me, might contribute by putting in the patients de-identified. So they might just put every patient they've seen because it's so rare with no names or date of birth. And so we sort of get a subset of the data. Or patients can directly enroll at some centers. They can always directly enroll through us, or they can directly enroll through the website, or I believe that Stanford and Oregon directly enroll as well. And so then we get a lot more data and can contact them for surveys, et cetera.
Awesome. That is so cool. So it's been 3 years and you've got 2,200 patients, which is incredible. Is there any data that you can share that's coming out of that, like preliminary or otherwise?
Sure. So we have, I think we have 17 active studies right now. Now, a lot of them, a handful of the early ones are on other disorders that people just have never gotten more than 1 or 2 written about. So there's some other rare conditions like arterial tortuosity syndrome. We just had a paper published. There's a rare disease called filament A that we just had a paper published. But there are, like I said, there are multiple papers in the works right now. So one is on the attention deficit disorder in any connective tissue disorders, including vascular EDS. One is on the effect of scoliosis. One is on looking at non-cardiac surgeries in these patients. So these are all ones that people have gotten the data and are sort of looking through and trying to write up. And then we're also using this as a base for prospective studies. Like we can probably talk about our study in a minute called HeartMath, which I don't remember if we talked about it last time.
I don't think we did.
Oh, I can bring it up.
I feel like I know that we've talked about it, but I'm not sure if it's been talked about on the podcast.
Oh, good. Well, I'm happy to talk about it in a minute. But the nice thing about Clarity is, we usually use it for collected data, but for the patients who've given us their name and their contact information, we can reach out and say, hey, we have this new prospective study. So it's also a jumping point for a handful of those. The main VEDS one is one called HeartMath. We're trying to plan sort of an exercise study, but we have to be very delicate in VEDS to figure out how to do that too. So
and I think I should probably get Siddharth Prakash back on here to talk about exercise at some point too, because he does some interesting exercise studies. So tell me about the HeartMath.
Sure. So HeartMath. So I'm going to take a step back. I have this amazing collaborator named Dr. Jennifer Bogardus. She's a PhD physical therapist whose daughter has congenital heart disease. And she and I met years ago because I'm actually her daughter's cardiologist. And she said, her daughter is doing really well from a heart perspective, but said, I really want to contribute to research. I have this PhD. I really want to push it further than just seeing patients. And I said, well, gosh, there's this paucity of data on, movement and exercise in the community. Maybe you could partner with me. And so we've been partnering together for over 5 years on different research. And one of her big interests that she's realized is biofeedback to help with anxiety. She's got 5 children. She really likes the mind-body connection and has realized that in her family, this biofeedback, heart rate regulation, self-regulation has really helped with things like anxiety and mental health. And she asked me, and there's a program called HeartMath that is one of these. It has, it's like an ear monitor that looks at your heart rate variability. And then you can do these breathing exercises or other exercises to control your heart rate variability. And she was like, is there a group of people, of your patients, that something like this might help with? And I said, well, gosh, our VEDS patients, a lot of them live with chronic anxiety or fear or trepidation, or even if it's adjustment disorder from just getting the new diagnosis. I think that could help that community a lot. So we're doing a pilot study of it right now, 40 patients. 20 patients will get the feedback and 20 will not. There'll be controls, but then afterwards they can get it. And we'll do blood pressure monitoring. They'll do a series of 8 sessions with Dr. Bogardus. It's all virtual. You don't have to come anywhere. And we'll mail the blood pressure kit to you. And we're seeing if that helps with symptoms of anxiety or quality of life and blood pressure, to see if just learning to regulate heart rate variability can help.
And is there a certain age group, did you say that that's for?
Yeah, I believe this one's very broad. I think it's like 10 to 40.
Okay. So like if you're in the United States and you're 10 to 40 and you want to be a part of this again?
Yep. And genetically proven VEDS. Yep, that's right.
Okay. How do you enroll in that?
So you can just shoot me an email. It's shainem@bcm.edu, SHAINEM@bcm.edu. Or if you want to enroll in Clarity, Clarity is clarityregistry.com, and there's a text box at the bottom where when you roll in, you can just say, hey, I'm also interested in heart math. And our coordinator for Clarity will then reach out to the coordinator for heart math.
Cool. So I'll put your email address and the Clarity Study website, which wasn't up in 2022.
Oh, yeah, that's right. Yeah, it's clarityregistry.com.
I'll put that in the episode show notes. So if you're listening to this and you're driving or you didn't catch that email address or website, it'll be in the episode show notes for you. That's Perfect. So cool.
And there's just a tab called Patients and Patient Enrollment. And that's just where you submit your information. And then our Clarity coordinator, Nadia, will reach out to you and do a formal consent. And then if you put any other notes, like you want to join one of our other studies, then she can connect you with the right person.
Yeah. And this might be a silly question, but for anxiety is a huge part, I think, of having VEDS, because there is something that in one of the group sessions at conference this year, I think I asked, how do you tell the difference between a panic attack and an internal bleed in someone with VEDS? And the answer was you cannot without a CT scan. I was like, okay, great. So my anxiety is valid. But so I guess the question would be like, if, it monitors your heart rate. So if your heart rate does go into like a danger zone, does it tell you, or you're still like responsible for that yourself?
Well, it's not, there's not really a danger zone in heart rate unless you're getting crazy high, like 180, 190, 200. And so, yes, I mean, this is kind of just like a sports watch. You don't wear it all the time. You just do it periodically. Mm-hmm. So it could tell you, but a fast heart rate could mean 1,000 things. Yeah. So it's not, we probably need a better warning. We are, as a side topic in that situation, we are investigating the use of this lab called D-dimer. I can't remember if we talked about that last time.
We did.
I don't have enough data yet. I don't have enough events in VEDS to sort of prove it, but we are collecting it every time we have someone coming in to see if it could be, it's a cheap, inexpensive blood test that if it's positive, it's not helpful. But if it's negative, we think that it's helpful to rule out an event. Although I did just have a patient come in. It was very sad. She's doing fine, but it was an 18-year-old with a headache. And we got a D-dimer that was normal, but her headache was new and severe. She has VEDS. And so we did get a CT anyway of her head, because if our risk is high enough, we should just do a CT. Mm-hmm. The D-dimer is meant for very low risk patients. And she did have a new carotid dissection, but she hadn't had imaging in a year. So it is possible that dissection is a few months old and the headache was random.
Right.
But it's hard to know for sure.
Oh, yeah. And that's such interesting research, too. That sounds like a very local thing that
Currently
you're doing.
Local. We'd love to do it more nationally. We just haven't had the funding to organize that. That would be great. Actually, I should apply for some funding.
Yeah.
But basically, what we do is anytime someone with VEDS or Loeys-Dietz or Marfan comes in with any concern for a arterial event, like some sort of tear, is that I try to get a D-dimer, and then we'll compare patients who are positive versus negative and what was the sensitivity and specificity of D-dimer. But at our local institution, we've been doing this for 2.5 years, and I think we have had 2 dissections. So,
okay.
You don't have enough power. So if we could do it multi-center, it would be amazing.
Yeah, that would be amazing. I would 100% enroll in that for sure.
Yeah.
So you mentioned you're at a big center. Mm-hmm. And you just said, I think in the last couple of years, 2.5 years, you've only had a couple dissections. So mm-hmm. Do you want to talk about changes in how VEDS is going? I don't know how to, or, even for Loeys-Dietz and Marfan too, because we have a lot of listeners in for those conditions as well.
And the caveat with my low, even though I follow a ton of patients, so I was mentioning before we got on that I think I follow about 60 young people. And if we count parents that I know and work with, it's probably 90 to 100 now. And so, and I hear about their events too. Part of the low numbers, I mean, part is that children have many less events than adults because the biggest predictor of an event is age, right? In VEDS, and hopefully it's also good management. So we have very few events, and the events that we have happened, people have done really well with in young people. I think they've noted right away because they've known the diagnosis, they've gotten care right away. And so I think the big overall trend is that it seems to me that people are getting diagnosed earlier and being made more aware. And that is hugely important because they get care right away. We can diagnose things right away. We can intervene if we need to right away, whether that is a surgical intervention, which often is not needed, but maybe it's a medication adjustment. Maybe it's just let's be quiet and chill for a while and not be doing this activity that might be exacerbating things. And so I think that's been a huge change. And of course, we've had medication changes, which I'm happy to dive into, we don't have awesome evidence, but there are 3 medications now that we're using more often. And I hope that they're adding to decreased events, although we need more data to know for sure.
Yeah. So there's a couple things for us to talk about there. So I guess let's talk about the medication first, like the medication developments. And earlier in this season, we talked to Dr. Dietz about his research, and I think that those are the medications that you're talking about. So if you're listening to this and you haven't listened to that episode, like go hop over there after this interview as well. It was a really exciting interview. So tell me more about those and how those are.
And this will be a little bit of a long story and a long journey, but just to kind of talk about how things are going. So the first, medication study that was sort of rigorously done or fairly rigorously done was a study published in 2010. So now 15 years ago, on looking at celiprolol, which is a European beta blocker. And that was called the VEDS study, and suggested that beta blockers might reduce events in VEDS, not vascular events. Now, that study had some limitations. Not everyone was genetically tested. It only had about 50 patients. And by the time they took out patients who probably didn't have VEDS, it was down to 30. But that study did show that even in that low number, the patients on beta blockers had less events. Because it was a small study and because it was not blinded, some people had reservations about that study. I still do. I'm an epidemiologist and I think a rigorous outcomes researcher. Beta blockers are have such a low side effect profile. And because they did show benefit, even with some study limitations, I've been a proponent of beta blockers for a while. So that has always been there. That is a medicine called celiprolol, which is now standard of care in most of Europe. And we don't have celiprolol in the U.S., so we use carvedilol or labetalol, or some people use atenolol or metoprolol. Any of the OLols are beta blockers. So that's one med that I use a lot and has been out there. The only people studying are the French group, and now everyone's on it, so it's hard to compare, but they've done a longitudinal study with decreased events. And so I think that's the first kind of baseline med. People think it's helpful. There was also a retrospective study, so a study that looked back. That's not quite as good a study design as a trial, but in Europe, and they looked at patients with VEDS. I know you've read that paper too. They looked at patients with VEDS who were either on a beta blocker or were on a medicine called losartan, and the patients who were on one of those meds had less events. So I'm optimistic about beta blockers. Now then, after that, a few years ago, Dr. Dietz's work, and I know you probably got a great summary from him. It was a little circuitous and a little bit accidental, I think, at the beginning. He was studying this medicine called enzastaurin, which is a possible new therapeutic in VEDS, but he was comparing other blood pressure meds that are used in humans to that enzastaurin and found that this medicine called hydralazine, which is a blood pressure med, might help reduce events in the mouse model of VEDS, but that was only effective till puberty. And the male mice started having a lot more events. And so we said, well, gosh, maybe male hormones have something to do with this. And ultimately, he tried this medicine called spironolactone, which has very mild anti-androgen, which is testosterone, effects. But we use it all the time in females, and we use it in male heart failure patients. It's got pretty mild side effects. And he tried it in mice, and it was highly protective. And so the question is, and then he tried it without hydralazine, and just spironolactone alone was highly protective. It has not yet been studied in humans with VEDS. But again, sort of like the beta blocker, it has minimal side effects. And the animal outcomes were so optimistic that there's been a lot of optimism in the community about this. We're trying to plan a study. Now, a few things about that. So the good side and the bad side. So the good side is that patients, this is a cheap generic med, over the counter, readily available. And right after the mouse studies came out, some people just got prescribed it because there's 1,000 indications. You can do it for acne or polycystic ovarian syndrome. And anecdotally in the community, people have been saying when they're on fairly high dose, like 100 milligrams a day, that their superficial bruising or vein ruptures are going down, which is exciting. On the other side, it does have mild anti-androgen effects. So there's a small percentage, mainly of males, that can have side effects like temporary breast development that's reversible. And so there's this balance. But overall, people are excited. Now, a lot of mouse studies don't pan out in humans. So that's, we have the one really good mouse study. And so we're waiting to see. But, I'm always really tentative about mouse studies. But seeing the patients respond, and again, knowing the side effects are minimal, I've gained some enthusiasm about this and hearing data in the community.
Yeah.
So that's the second med.
So,
and then I can talk about one more, but I don't know if you want to ask a question.
Yeah, I do want to ask a question about that, because I know a lot of people with VEDS are getting on spironolactone. Mm-hmm. If you're enrolled in the Clarity study and you're on spironolactone, does that get tracked?
Yes. So we have a special form. It's a monthly form that goes out to you separately. Now, this is not if your provider puts you in Clarity blinded, you do not get it. But if you enroll directly with us, then you will get it. The only tricky thing is you have to do it. If you don't do it, it stops coming to you. But it's a monthly symptom survey that just says, how's your bruising? How's your bleeding? Have you had any events? How's this? And it's not just for people on spironolactone. We want everyone on it because we want the people who aren't on spironolactone to compare events. The real way to study side effects is a trial. But while we're waiting for the trial to get done, we're collecting data through Clarity. So we'd love for people to join, whether you're on spironolactone or not. And we're looking at data on all the meds. So every month you say what meds you're on and what your symptoms are, and if you've had any major symptoms or major events. And then we'll go back and compare the patients on spironolactone to not spironolactone, controlling for, of course, variant in age. But we need a lot of data.
Yeah. How long does that take?
We're just in perpetuity right now. It's every month. Every month it's a little quick app thing you fill out.
But how long does it take, from a researcher perspective, how long does it take to get enough data? What is enough data to say?
Yeah. So you need enough people who've had events or have symptom changes to not symptom changes. So you need a fair number. I would guess we need at least, I haven't done a formal sample size estimate, but I think 50 people in each group for probably a year or two.
Okay.
To know. Now, what Dr. Liang, who's a cardiologist at Stanford, who's lovely, has talked about doing a formal bruise testing, having some sort of standardized hammer where you can hit people. I know that sounds crazy, but I actually love the idea.
Yeah.
A standardized bruising, and then you could look at it over time as a biomarker, is the bruising getting better? And so we've talked about possibly doing, because right now we're just saying, is your bruising better?
Right, it's all subjective.
Yeah, it's subjective, and hormones affect that. Teenagers, sometimes we see it get worse in puberty. And so it's a little hard to track that over time. And so that the more things we can make standard, the better. But at least we're collecting some data.
Yeah. So what's the third medication?
So the third one is a medicine called irbesartan, which is related to that medicine I mentioned, losartan, earlier. So to take a step back, Marfan syndrome, which is an unrelated condition, Dr. Dietz also found that this medicine called losartan, anything in sartan is an angiotensin receptor blocker. It's kind of blood pressure med that kind of tricks your kidneys into lowering your blood pressure, but we think has other effects as well. He found that in Marfan syndrome back in 2006, that in a mouse with Marfan syndrome, that it halted aortic root dilation. So it seemed to have some effect on the aortic wall, probably moderating this, something called TGF-beta. And so and then we did human trials, and it turns out losartan slows aortic growth in Marfan syndrome. So there's been some thought of using losartan in VEDS for quite a while. However, in the American mouse models of VEDS, losartan has not had much of an effect. So some people were using it just for blood pressure control. In northern UK, they were using it in VEDS. But what was interesting in the mouse model of VEDS, when they added irbesartan, which is a sister of losartan, to celiprolol, which they're already getting in the mouse model, the mice had a lot less events. So I don't know why the French mouse was different than the US mouse. But they did, and I don't know if the study was done a little bit differently, but the French mouse model, it looked like addition of an ARB to a beta blocker could be helpful in reducing events. So they did a small trial published last year in humans. I don't remember, it wasn't very many, maybe 30 or 40 people with VEDS, and they randomized them to placebo versus irbesartan while already on baseline meds. So most of them were already taking celiprolol. And the group who got irbesartan, in addition to their baseline therapy, had less events. Mm-hmm. So, which was really exciting. So, and we know that combination, beta blockers from ARB, is what we do in Marfan and Loeys-Dietz too. So it's a common combination. And so that was exciting, bringing in possibly a third medicine. And I know it gets confusing because it's 3 meds.
Right.
But in Marfan syndrome and Loeys-Dietz, we use those 2 meds together all the time, a beta blocker and an ARB. So the fact that it works or could work in VEDS makes a lot of sense.
Yeah, I remember reading that study, and I think that was the one that made me go, okay, I'll add it.
Fine.
Because it's small and it's limited, but like that's part of the challenge of having VEDS and research in VEDS is that research is often small and limited because we're a rare community.
That's right. And if you can do, the hardest studies to do are human trials. They're very hard to get funded because you have to recruit patients, you have to follow patients in a standardized way. And both the celiprolol trial and the irbesartan trial are human trials, and so there was standardized data collection, there was standardized people talking to all the patients versus retrospective patients like retrospective studies like the UK study, and currently where Clarity is, where we look back on what's happened. Those are subject to confounding. Like the groups might be, like the more educated people might be on more medications. Mm-hmm. And so then you're actually seeing an education effect rather than a medication effect. And so at least those 2 studies were proper trials. And so they're small, but done pretty well.
Yeah. So someone listening to this might be very enthusiastic about it or also might be very confused about it because there's a lot of different things that we're talking about. So where would you recommend somebody listening to go and learn more about this? About these?
Yeah, well, the Marfan Foundation site, which is also the VEDS, which harbors the VED movement site, has a research letter about this. You could also look at your podcast with Dr. Dietz. And I think talk to your provider. Data is emerging all the time about these. What's nice about VEDS is it's changing rapidly. Like that irbesartan study is less than a year old. I think a lot of providers don't even know about it. And so just keeping up to date on these circumstances. But for now, I think the Marfan Foundation website or VEDS movement website and probably that podcast. And we had a recording from about a year ago. Yeah. Probably have the most information about the current method.
The webinar, right?
Mm-hmm, the webinar.
Yeah, that was a great webinar. I'll put that I'll put those links are always in the episode show notes for the Marfan Foundation, the Loeys-Dietz Syndrome Foundation, and the VEDS movement. But I will make sure to add specific links to that webinar that we mentioned as well.
Oh yeah, and that was just recent. Sorry, because that was an updated one, the webinar that just happened.
Yeah.
That was briefly talked about it, but it was done very well, I think.
Yeah, I think so too. There's been a shift in the level of hope that I'm feeling. I don't know if sometimes I feel kind of isolated over here, which is ironic because I talk to everybody. But it feels like there's been a shift in the level of hope as far as treatment for VEDS definitely since I was diagnosed, but even since a few years ago. Do you feel that on your end?
I definitely do. And I definitely have more hope too. And I think it's both the fact that we have medication treatment, and I think that people are seeking care earlier. We don't always have to intervene, but when you recognize things early, then you can get care. And so I think just people knowing and advocating for themselves in emergency situations, plus medications, I think both of those are helping tremendously. And I think also we were so afraid of VEDS in the past, we didn't even want to intervene when there was something intervenable upon. And I think that has changed too. So I think all of those, if you look at curves from Dr. Shalhoub or look at curves from the French group that has a large cohort, the survival is increasing. And so I don't know, I definitely have hope. We have a lot more work to do, but it's definitely increased for me.
Yeah. Where do we find those updated survival curves? Because often, even with people who are newly diagnosed now, they're still finding that 48 or 51 number.
Yes. You're right. Well, the French longitudinal study, so it was a longitudinal study of celiprolol, but it's basically most of their population that got published maybe 3 years ago. If you just look like observational longitudinal celiprolol and VEDS, I think you'll find it. That's the French one. I do not believe Dr. Shell-Hoobs has been presented outside an abstract, but hopefully it'll be coming out this year.
Okay. Oh, that would be great. I need to get with her too for an update because there's a lot going on, and sometimes it feels like there isn't.
Right.
Like sometimes it just feels like, what is happening with research? Why don't we have something? Why don't we have an answer? And that's a really like human response, I think, to dealing with VEDS. But there is a lot going on when you start talking to people who are like in the know.
Yes, there's a lot. And it's hard because you also, the way that publishing, which is, putting in a journal to be peer reviewed, which is quite hard to get it published, is, they always want large studies. They want these really firm outcomes, and VEDS is small. Mm-hmm. And so even though we might present preliminary data, getting it to a final place where it's publishable can sometimes be hard. So they sometimes want more data. They sometimes want more questions answered. So sometimes things have to go back to the drawing board before a journal thinks it's strong enough to be published. Okay. So that's why sometimes things are in abstract form, or you'll see it presented at a meeting, but it's not in a formal journal yet.
Got it. Okay. So I think a few years ago, too, when you were launching this Clarity study, there was some pregnancy research going on in conjunction with that. And I think I've heard some updates from that. Kind of like you said, it's an abstract form or something where you hear about it at a meeting or something, but it's not fully published yet. Has that data been published yet? From that study?
So there's a little bit. So I know Dr. Russo collected a little bit for PROGAD, which was a research study of women in pregnancy with connective tissue disorders. Although I recently talked to her about that study, and I think there were not enough VEDS collected for her to report. She is publishing soon her data, but it's on Marfan and Loeys-Dietz. Okay. She recommended that all the pregnancy data be contributed to Dr. Shell-Hoob's longitudinal study in pregnancy. And then we are collecting it in Clarity too. We did publish a paper 2 or 3 years ago, but it was focusing on children born with VEDS and their mothers. And so a little different. So some of the kids were, some of the parents were affected, but it was more focusing on childbirth and birth complications, which were common. Mm-hmm. That's when we showed that preterm delivery is associated with earlier events in the child. And we think it's because the amniotic sac of the child, that's their own DNA and it represents their own fragility. So if you're born before 37 weeks, you're more likely to have an early event. And we did some pregnancy reporting in that paper, but we just had a handful, I think 8 or 9. And so we have collected quite a bit of pregnancy data in VEDS, and so has Dr. Shell-Hoob. So we need to combine to get that longitudinally published.
Okay.
I think it was sort of, we have it in 3 different places: PROGAD, the VEDS longitudinal study, and Clarity. And we just need to get it together because they're all smallish groups.
Yeah. So then if you combine those, you have a bigger group to look at. Is that still enrolling too, or is that part been...
The VEDS longitudinal study or natural history study?
Oh, that one's still enrolling. So it's just part of it.
I think is paused right now.
Okay.
For enrollment. But if you contribute to the natural history study or to our study, Dr. Russo, who runs PROGAD, is one of the only geneticists/high-risk OBs in the United States. And we always collaborate with her for any pregnancy study. So even though I don't think her study is enrolling, she would be involved in any of these long-term studies.
Perfect. Yeah. So it sounds like there's a lot of ways for somebody to get involved in research if they're listening.
Yeah, absolutely.
What research opportunities? It sounds like mostly like you focus in VEDS, but you also see for your research, but you also see Marfan and Loeys-Dietz patients. So what opportunities are there for people with Marfan and Loeys-Dietz to enroll in studies?
We have a lot going on in that space too. So in Marfan syndrome, besides joining Clarity and looking at longitudinal outcomes, we actually have an exercise trial going on, which is really exciting. We did a pilot study with the Marfan Foundation a few years ago where we took 20 kids. We tried to tell them to exercise and then follow them, and that didn't work. So we changed it to virtual coaching twice a week, and we did it for 8 weeks, and we did 20 kids, and we saw that their fitness level, their stress went up, their stress levels went down, their heart rate went down, their blood pressure went down in a small group, with just 20 patients. And we got funding to do a big study. We're doing 50 patients, training 3 days a week between California and here with patients in California and in Texas. And that was really exciting. That is a randomized, controlled, blinded study. And we just enrolled like our 39th patient, I think. We're doing 50. So that study is almost done. And hopefully we can't look at the results till the end, but we know that patients are very happy in it. They get randomized to do this exercise intervention with a trainer, all virtual or not. And that's for 10 to 25-year-olds. Most patients love it. We have a few of our younger kids are like, that's hard. But most people love it. And our goal is to really change the field to show people that it's safe. We're doing moderate intensity exercise, and we're trying to show people that it's safe so people lighten up on the restrictions for young people.
Yeah.
And then our next goal is we just applied for funding to investigate weightlifting in Marfan syndrome.
Whoa, that's a big one.
Yeah, I don't know if we'll get to that for VEDS, but in Marfan syndrome, people have put these kind of made up weight limits. And so we're seeing if there's a way to predict personal safe levels.
Nice.
If we get
that
so
would be
in other
nice.
words, we're trying to raise money to do that.
Yeah, I feel like those weight limits are also kind of made up. There's also made up weight limits in VEDS too. I think. So
it's all made up. And that study, the weightlifting study, is actually Marfan and Loeys-Dietz.
Yeah.
It's just VEDS. We love to do it, but it's just so much more delicate in VEDS.
Yeah.
So, because you really could cause a vessel rupture versus Marfan and Loeys-Dietz, that's so rare unless you're doing like really, really heavy weights. So we feel pretty comfortable doing like graded increasing weights in those groups. Mm-hmm. VEDS we're a little trickier. We might start with some low level cardio.
Yeah.
Everything out there is just so subjective. Now we're trying to get real data that we can build on.
Yeah. I think you were about to say how people enroll in that.
Oh yeah. So that way is Akaris Bonilla is our person. I can give her email. Or you can go to the Clarity website and just say, I want to enroll in the exercise study as well. But let me pull up her email really quick.
And for that, you have to be in California near Stanford?
Well, you have to, for the exercise study, you have to come at the beginning and end for an all day. You get an MRI, you get an exercise stress test, you get arterial stiffness testing, height, weight, mental health surveys, and quality of life surveys. You have to spend a day with us and then a day with us 12 weeks later. So you can live anywhere if you're willing to come to Houston or willing to go to Stanford.
Okay.
So those are the requirements. And you can't have had aortic surgery. And you can't have had spinal rods because the spinal rods make the MRI pictures not so good, and MRI is our main tool.
Okay.
But if you have no back surgery, you're allowed to exercise, no aortic surgery, and you're between 10 and 25, and you're willing to come to Houston for 2 days or Stanford for 2 days, you can enroll.
And you have Marfan or Loeys-Dietz.
Oh, and the current one, exercise trial, is Marfan.
Okay.
The weightlifting trial, we need to get money for first.
Okay.
we have to raise funds. Let me just give Akaris's email if you want to enroll in the exercise study.
Sure.
It's OKARYS.Bonilla, BONILLA @BCM for Baylor College of Medicine.edu.
Perfect. I wrote that down. I will add that. I feel like this episode show notes is going to be so long with like,
I know, sorry.
enroll this, which is awesome.
Yeah.
I mean, that's like a really big thing that there are so many research studies to be a part of if you have one of these conditions. Is there anything else that you want to share on research in Marfan and Loeys-Dietz?
No, just the perpetual, please. One thing that's amazing about the VEDS community and Marfan and Loeys-Dietz is the patients are so involved and advocate. And I think that's really critical. And I think people just need to keep joining research studies to push everything forward. In the rare disease communities that have made significant improvements in life care, like in cystic fibrosis, had very active patient communities. And I think both just making sure you're enrolled in as many studies as possible to contribute, and for people that are able to contribute towards funding, it really helps move us forward. Almost all of my research is funded by philanthropic efforts. We get a little from the government, but the government, especially right now, isn't doing a lot of rare disease and pediatric research. We actually lost some of our funding from the government. And so the more people can contribute, both with their personal information, and then if they're able to fundraise at all, it really, really, really helps.
And how do you, if you do have the funds to donate, how do you do so?
Great. So you can, I can give you another link.
Okay, perfect.
You can always comment through Clarity, but we also have, if you go to with the aortopathy and arteriopathy research fund for us, there's a donate now button. If you want to donate now, or you can reach out to me personally. That's for our specific work. Of course, you can always contribute to the VEDS Natural History Study or to the VEDS Collaborative through their organizations as well.
So many ways to get involved. Yeah. I love it. Is there anything else you want to share with people as like a parting note?
Good.
Or
Well,
any other research that you want to share?
Yeah, no, I mean, just that like you, I'm optimistic and I'm hopeful. Both it's seeing increased diagnosis and increased awareness and improved outcomes. And I think we always need to keep moving forward. But I don't remember being more hopeful than I am now.
That's wonderful. Could you actually, before we go, could you also, because there are so many people that I talk to now that have just been diagnosed, it feels like they have an event, they get diagnosed, and it's like, sometimes it's as short as a couple weeks between when they get diagnosed and when I hear from them, which tells me that like the community, like they're getting connected to the community faster. Is there any message that you have for those people who are like just getting into the space, maybe feeling overwhelmed by their diagnosis?
Yeah, I mean, I think, getting a diagnosis like this, especially if you're, like late teen or adult, can be very overwhelming, as you mentioned, and people cope with that in a lot of different ways. And one common way of coping is either denial or avoidance and, kind of pretending you don't have it and or trying not to connect. And I do see that a lot in clinic. We try to get people connected to communities and they're like, I'm not ready, which is totally fine. But if there's one thing that you can work to overcome, I think being part of this community is so incredibly helpful. Even just meeting one person, I'm happy people are reaching out to you. We do have some people who just can't. And so if you're able to reach out and connect to someone, it's not as overwhelming as you think. Almost everyone I've met who does it and touches the community has meaningful benefit from it. So just, people are there to support you. There's not a lot of expectations. So, please use the resources out there.
Cool. Thank you so much for coming back on and sharing your research and for doing all of this research. I think I really, really appreciate it.
Awesome. Well, thank you for hosting this podcast and having something for patients. It's so wonderful.
Thank you.
All right. Thanks, Katie.
Thanks for listening to this episode featuring Dr. Shaine Morris, a pediatric cardiologist caring for people with VEDS, Marfan, and Loeys-Dietz at Texas Children's Hospital. If you're ready to meet others, get involved, or need support, there are links for you in the episode show notes, as well as information on research studies for people with VEDS, Marfan, and Loeys-Dietz, including those with the VUS. Any links or email addresses mentioned in this interview with Shaine are also down there in the episode show notes. If you like this show, be sure to share it on social media or give it a rating or review. You can also support the production of this podcast by joining my Patreon, making a one-time donation, or by buying merch. As always, my top tier patrons are listed in the episode show notes. Thanks for listening, and I'll see you soon.